Assalamu alaikum. Good evening. We will start because we are behind the schedule. So welcome to the second MENA Club for Rare Diseases. Today we have a distinguished speaker. I think I shouldn't introduce Dr. Dina. Dr. Dina Saleh is well known to all of us. She's consultant and head of division pediatric neurology, and she worked in several places. Now she's in Reem Hospital. She's also carry academic titles from both Khalifa University and Ain Shams University, and soon she'll be full professor, inshallah. And she will give us a very interesting talk about Pompe. So, Dr. Dina.
Thank you so much, Dr. Ayman, for your generous presentation. And I'm very delighted and happy to be among you today, and want to thank you all for taking the long way after a long, tiring way day in the clinics, and your duty timing late in the evening to attend our meeting. And this is, as Dr. Ayman mentioned, is the second MENA Rare Disease Club meeting sponsored by Sanofi. Today we'll shed light on Pompe disease to look beyond the obvious. So the learning objectives of our meeting today is to understand the mechanism of Pompe disease and to understand why glycogen clearance is impaired and the role of the mannose-6-phosphate receptor pathway in this the pathophysiology of this disorder, and to recognize the Pompe signs and symptoms and to look beyond the obvious and to look beyond our scope of subspecialty. Diagnosis is very important. It's very simple, and this is the aim to raise the awareness about Pompe disease. So Pompe disease is a degenerative muscle disorder. It's also known as a lysosomal storage disease due to deficiency of alpha-glucosidase enzyme, and this results into the impairment of the glycogen clearance and accumulation of glycogen in the muscle fibers that was predominantly affecting the skeletal muscles. As you know, it can affect the smooth muscles and the cardiac muscles to a less extent. It's predominantly affecting the proximal muscles of the upper and lower extremities, and also it can affect the diaphragm, which is the main reason why these patients suffer from respiratory difficulties. So, and unfortunately, it's a relentlessly progressive disorder, and eventually the patient will end up having a wheelchair bound and have a ventilatory dependence that will cause premature death and impair the quality of life for sure. And the misdiagnosis is very, very common and frequent because many muscle diseases present with weakness and impaired ambulation. So it takes sometimes up to 10 years, average 10 years of shopping between physicians and being misdiagnosed. So early diagnosis is the key to earlier disease management. Now, looking into mechanism of Pompe disease, so it's very important to understand that the routing of the GAA enzyme into the lysosome is very important for the clearance and of the glycogen, in the conversion of the glycogen into glucose, and hence it is catalyzed by the GAA enzyme. The GAA enzyme is synthesized in the endoplasmic reticulum, and after that, in the Golgi system or apparatus, it is tagged by the M6 phosphate, and this is very important and essential step so that it can be recognized by the mannose-6 phosphate receptors, and at the end it will be released in the early and late stage to the through the vesicles to the lysosome to go into the process of the glycogen conversion into glucose. So if the GAA enzyme is deficient, this will result into the accumulation of glycogen in the muscles with the resultant impairment. So this slide is very nice slide showing the accumulation of glycogen in the muscle fibers. And as you can see here in the beginning, this is lysosomes are engorged with the glycogen, and in the electron microscopy you see that this still the functional muscle, there is no functional muscle impairment. So the symptoms can really very subtle and very difficult to identify. Later on, this becomes progressive and irreversible damage that will completely substitute the muscle fibers. Now, we know all in genetics that there is phenotypic presentation and there is genotypic presentation. So the phenotypic variability depends on the number of genes or the variants involved. So if we have individuals Pompe disease have two pathogenic GAA variants, and these actually variants affect the severity of the disease and the presentation. So if depending on the pathogenic GAA variant, the patient may experience two types of Pompe disease. So if we have two severe variants, then the patient would present with a severe form, which is the infantile-onset Pompe disease. And if we have a one severe and one mild variant or two mild variants, pathogenic variants, we will have a residual enzyme GAA activity with variable onset, variable presentation, and presenting with late onset Pompe disease. And in these patients, it's really challenging because they can be missed for years because the presentation is not striking and can be misleading and overlapping with many other muscle disease that present with muscle weakness. Now, how to recognize the symptoms? And this is Professor Pompe, and the first patient with Pompe disease was described at the age of 7 months, where the infant presented with huge idiopathic hypertrophic cardiomegaly, hepatomegaly, and hypotonia, and this was the first case described. Now, this is a classification that the same idea about how many variants are involved, and based on the variant involvement, we have either the classical form or non-classical form presenting below the age of 1 year and according to the level of enzyme activity, and we have the late onset form that presents after the age of 1 year, where there is some residual enzyme activity with a later onset and later age of death. Now we'll go through first the clinical spectrum of the infantile onset Pompe disease. And the classical form, usually they present approximately around the age of 1.6 months, where you have the mother coming with a child who has feeding difficulties, who have excessive drooling of saliva and secretions, poor weight gain, and usually there is paucity of movement, poor head and neck control, and also recurrent chest infection and sleep disorder breathing. On the signs would be mainly, of course, the failure to thrive. The infant might have macroglossia, cardiomegaly, and cardiac murmur, as well as hepatomegaly. If they present at a later onset, but still below the age of 1 year, this is non-classical form, and we can see similar symptoms and signs, and usually death is in the first decade of life. And this is an X-ray showing a huge cardiomegaly in these cases. The other thing is that the neurological examination is really very, very important. So usually the children are alert, so it does not affect their cognitive or mental status, but they are grossly delayed, they have muscle weakness, they have hypotonia, they have also, the hypotonia is really profound, so it's truncal and appendicular, and there is a significant head lag and poor head and neck control. Deep tendon reflexes are either absent or diminished. This slide is really very important. So if we have pediatricians, general pediatricians among us, they should be able to identify the most important symptom, which is hypotonia. And this is how we examine any infant with hypotonia. So inspection is really very important. So in neurology, an inspection is very important to see how the child is lying. So if we can see in the upper photo here, this is a normal muscle tone where the baby looks having a semi-flex position of the shoulders, elbows, hips, and knees. But here you can see this is the well-described frog-like position where you can see abduction of the hips and complete truncal and appendicular hypotonia. On a trial to pull the child to sit, so you can see here there's a very good head and neck control. You can see flexion of the upper and lower extremities, but in the lower photo, this is a clear evidence of hypotonia with significant head lag and poor head and neck control with extension of the arm. So usually there's some resistance to pulling to sit, but here you see that the arm is fully extended. Now, this is another thing. This is the vertical suspension and the ventral suspension. So in the vertical suspension, you can see that a normal child should be having a semi-flexion of the upper and lower extremities. Here, the child is usually slipping from the examiner's hand. Now, on the ventral suspension, you can see this is like an inverted C appearance because the truncal tone is very, very low. So you can see the significant head, poor head and control. But here you can see that the child is trying to lift the head up. Okay, now moving on. So this is a very important. Whenever we have these constellation of symptoms, a child who is having hepatomegaly or cardiomegaly, who has feeding difficulties and failure to thrive, who has recurrent chest infections and hypotonia, we need to think for infantile onset Pompe disease because it's very progressive, it's rapid, and it's fatal within the first year of life. Now, moving to the other form of Pompe disease, which is the late onset Pompe disease, and this can be easily missed, as I mentioned earlier, and it has characterized by affection of the progressive myopathy is the most common feature where there is affection of the proximal muscles of the upper and lower extremities, and also there is affection of the respiratory muscles, mainly in the diaphragm, and diaphragm is very important for respiration. So in the next slide, we'll see also when we have an impairment of diaphragm, so we have the inspiratory muscles and we have the expiratory muscles. These muscles work in order to compensate for such weakness. So we start using the inspiratory muscles. The patient will start have a chronic sleep hypoventilation. He will have a lack of restful sleep, early morning headaches and fatigue, and also neck and head and shoulder pain due to the use of these muscles. When they are using the expiratory muscles, mainly the intercostal, subcostal muscles, then the patient will start have difficulty with the airway clearance, with the pooling of the saliva and secretions, with a recurrent respiratory tract infections. Eventually, the patients will suffer from motor and respiratory function difficulties. And if we looked at this slide, so in the natural history of the study of 94 adults who suffer from late onset Pompe disease, we will find that the shoulder, abdominal, paraspinal, and hip muscles are involved and they are weakened by more than 80%. And if we looked at respiratory dysfunction, we'll find that 92 children and adults with Pompe will have 74% of them will have pulmonary dysfunction. This will eventually lead to being wheelchair dependent or the result into premature death due to respiratory dysfunction. So if we looked at this slide, also in this study, they found that every year, 13% per year, there is an increase in wheelchair dependency, and there is an 8% increase per year in ventilator dependency. This is a very important slide for those who are subspecialized. So if I'm speaking as a neurologist, we are always focused on the neurological symptoms. So we are always focused on the weakness. We are always focused on the difficulty of walking, about pain, headaches, disorder, sleep pattern. But we have to look more broader. So we need to focus on other symptoms which are cardinal in patients with late onset Pompe disease, such as GIT symptoms with gastroesophageal reflux, such as rapid breathing, such as ptosis, and most importantly is the multiple referrals. So you will see this patient have been seeing the neurologist, they've been seeing the pulmonologist, the gastroenterologist. So when we find the patients who have been seeking different specialties, we have to think Pompe. Okay. Now, for the pulmonology, of course, the focus will be on the respiratory difficulties, on the sleep apnea, on the restrictive lung disease. So they have to look for the other symptoms, GIT symptoms, muscle weakness, and so on. The same apply for the gastroenterologist. We have seen, I remember I had attended a meeting where a neurologist from Qatar presented a patient with late onset Pompe disease, and the main complaint was the change of the voice of the patient. So, and the tongue was progressively increasing in size. This was very rare, and you've been seeing ENT to check for the vocal cords, and it ended up having late onset Pompe disease. So diagnosis early is really very crucial and important, and especially it's very simple, and it's readily available in our office. So Pompe disease, once suspected, we do CK levels. If the CK levels is increased, then we can use this very simple test, which is dried blood spot test. We can put few drops on these circles, and we get the results of the enzyme level. So if the enzyme level is low, definitely we need to confirm the results by doing gene mutation analysis. Now, this is also a very important slide because this slide actually, it's the differential diagnosis for all cases of infantile onset Pompe disease and late onset Pompe disease. So the diagnosis early is very important in order to start the treatment plan and to have an expertise managing these patients. And the patients with infantile-onset Pompe disease can be misdiagnosed with spinal muscular atrophies, congenital hypothyroidism, congenital muscular dystrophies. They can be confused with peroxisomal disorder, mitochondrial disorders, and so on. And for late-onset Pompe disease, we have been seeing many patients who are suspected to have limb-girdle muscular dystrophy. They have been suspected to have Duchenne-Becker muscular dystrophy, myopathies, metabolic myopathies, and myasthenia gravis and polymyositis. So once the patient is diagnosed according to the consensus for Pompe disease guidelines, this patient needs to be followed and have a coordinated care with multidisciplinary team that is led by an expert physician in the field. And for infantile onset Pompe disease, they might need a serial cardiac assessment, they might need respiratory assessment, GIT assessments, they might need to see a dietitian for failure to thrive, gastrostomy tube placement, and of course, neurology and metabolic assessment. For the late onset Pompe disease, also according to most important or most impending symptom for respiratory difficulties, genetic counseling, physiotherapy, and occupational therapy, because they have to cope with the changes over time and the limitation that they will face during their treatment journey. This is a very important slide, and it's a summary for everything that we've been talking about. So again, this is the main points that we need to focus on. For the infantile onset Pompe disease, the genotype-phenotype variability depends on the GAA enzyme activity, which is mostly less than 1%. That's why the onset is very early, the course is very progressive and fatal and usually lethal before the first year of life. Usually they present with cardiomegaly, hypotonia, respiratory difficulties, failure to thrive. The outcomes, it's very poor, and they require usually invasive ventilation by 6 months of age, and they have the most common cause of death is cardiomegaly or respiratory failure. And also recognition is really very important. As for the late onset Pompe disease, the inheritance, as I mentioned, depends on the enzyme activity and how many variants are involved. So the enzyme activity will range between more than 1% up to less than 40%. They have variable onset and hence progressive course, and the course is variable according to the enzyme activity. They are mainly presented with muscle weakness in the skeletal muscles and respiratory difficulties, and probably progressively they will need a wheelchair and ventilation dependent. Both are commonly mistaken for other conditions due to significant diagnostic delays, and the prompt diagnosis is really critical to start the early treatment plan. It's very simple, just a simple dry blood spot test to check for the enzyme activity. Once the patient is diagnosed, a multidisciplinary team with an expert physician in the field need to lead the team for addressing the patient's disease manifestations. If you would allow me, I would share with you a real case scenario for one patient with late onset Pompe disease.
Hi, my name is Johan van Wyk. I'm a 42-year-old clinical psychologist, and I live in Dubai with my lovely wife and our 3 beautiful daughters. Playing guitar, or painting, or taking a long ride on my motorcycle are my hobbies. Since I was 8 years old, I experienced joint and muscle stiffness and pain. As I grew older, it just became worse. I felt increasing weakness in my legs, my trunk, my arms.
I can summarize for you I'm sorry?
Several different diagnoses were made since I was 23 years old. The initial idea was that I had arthritis, like rheumatoid arthritis, psoriatic arthritis, neuromyotonia, limb-girdle muscular dystrophy. Starting in my 30s, I had trouble falling and staying asleep, and often woke up with morning headaches. I felt very tired and was short of
breathing
breath
difficulties,
even when resting.
simple exercises that
This
he
progressed
was
into
not
excessive
able to
snoring,
do it.
which disturbed
He
my
was
wife's sleep.
at the age of
I was
15.
often tired and
So
unable to accompany
all this
friends and
he
family
was in this
on
diagnosis,
recreational
obviously.
activities like hiking,
And
horse
the
riding,
thing is that
or
we
sport
need
events
to
with our
continue
children
to be
due to my
aware of,
exhaustion and
looking
breathing
outside
difficulties.
our
I
schedule
continued
for
to consult
subspecialty
with
to be
several
able to
specialists
pick
over the
up
years
late-onset
as I
disease.
continued not to feel well. By then, I had seen general.
Thank you so much. This QR code you can use to download the booklet for the lysosomal storage diseases, and you can have an idea about rare diseases, guidelines, everything. And can I move to the next slide? Everyone is okay? Okay. And this is a this is an invitation to everyone. This is the MENA Congress for Rare Disease. It's one of the largest events for rare diseases in the region that we will be held in May. And it's for 4 days, 25 CME hours, more than 120 speakers. And I would encourage everyone, Sanofi is generously providing the 50 invitations, registrations with 75% discount for the first 50 physicians who were registered in the meeting. Thank you so much. And I'm happy to take your questions, of course. Yes, sure. So Mohanna can tell us if anyone has any question, and then we will wait for the virtual questions to answer. Yes, sure. Sure, please.
Good evening, everyone. I'm Professor Anil Israni. I'm fairly new to the UAE. I moved from Liverpool, Northwest England. So thank you for the excellent talk and for giving us an overview of Pompe's disease, which can present in a multitude of ways across the lifespan. So one of the screening methods to detect this condition early is by doing a screening lysosomal enzyme assay on a dried blood spot sample for alpha glucosidase. The problem that we had encountered in newborn screening was that there was a lot of false positive. And it's a second step because the GAA, gene analysis, takes a while. I wanted to know your views on the use of urinary tetrasaccharide excretion as a second screening test for Pompe's. That's my first question. And my second question, or rather an observation is, and which is a very peculiar observation, is the early involvement of diaphragm, which is a differentiating feature in Pompe's disease, which is quite unusual for other myopathies or muscular disorders. And when we try to investigate, what we found is that when we did the EMG of the diaphragm, we found fasciculations there, meaning thereby that there is also involvement of the anterior horn cells in addition to the muscle. So those were some of my comments. Please accept my profound congratulations on your amazing talk. Thank you very much.
Thank you so much for your comments. For sure, I totally agree with you. And regarding the screening, urinary screening, so being here for 15 years, I know sometimes it's in government, everything is easy. So you can do whatever investigations you want. Of course, this can help, of course, as a confirmatory test because the enzyme, let's say, we had a previous case, I think Dima might remember. So we have a case who presented with a possible late-onset Pompe disease, and we did the GAA enzyme, and it was low, and we went for the genetic test as well. And the genetic test was giving like most likely it is a Pompe disease, but it was not conclusive. So sometimes we need additional, definitely, tests to confirm this. But as a screening tool for readily available in the clinic, I would really encourage having the dried blood spot for pediatricians, you know, for orthopedic, for this is really very good. Now, since you are here and I heard that you are really interested in neurogenetics, this will be great actually to started as a focused and as a subspecialty clinic in Tawam Hospital, that would be great. And Tawam Hospital is well known for a long time in the neurogenetic, in the metabolic clinic. I don't think in Abu Dhabi, the metabolic clinic does exist, but it is not as old as Tawam clinic. So it would be great to have like to have our own consensus and our own guidelines, stepwise approach to diagnose Pompe disease and other neurogenetic and metabolic disorders, but taking in consideration the limitations for those who are seeing physicians in the private sector whose their insurance will not be covered, because previously I was working in Mafraq Hospital government, and some patients has to pay 5,000 K just to see the physician. And to order any of these tests, I would send them to their home country to do it and bring me the results. So imagine how difficult it was. Okay. So Mohammed, there is the virtual was on, because I've seen some comments that did it start. Okay. Okay. Thank you. Okay. So thank you so much for your patience and for your attention. Thank you.